but I'm not too fussed about that. It's got a high group 10. That's very high, certainly in terms of European standards. A 9% preterm delivery rate is very high. When I go to the breaches are only 2.2% in size. I find that very hard to understand, especially when there's so many nullips, and especially when there's such a high preterm delivery rate. Because if there's a high preterm delivery rate, you would expect more breaches. Does that make sense?
Yes, it does.
So that doesn't quite fit to me. So I think the breaches maybe somehow found themselves into other groups. I don't know which. Going down within the section rates, with that kind of ratio, 11% section rate is higher than ours. Ours was 8%, but it's kind of, you know, not bad. It's not that high. This obviously is quite high, certainly very high considering the size of Group 2A. So we've got a lot of pre-labor sections there. I know there's a lot of pre-labor sections because if you induce nullips at term, in most parts of the world, it will be anything between a 25 to 30% or 20 to 30% section rate. So there's a lot of pre-labor sections here, as there is in Group 4. Group 4, if you induce a multip without a scar, you should have a section rate of about 6-7%, maybe 8%. There's a lot of pre-labor sections in Group 4. And that's interesting to me because Group 4 are the ones that are easier to induce. So I'm just wondering why there's such a high section rate. And my first thought on that, as I've said before, is it data collection? Is that collected correctly? The second thing, are there any epidemiological factors? I would have to get more information from that. But lastly, in terms of clinical practice, the most common reason for a pre-labor section in multips without a previous scar is maternal requests. You have a bit of placenta previa, you don't have too much IUGR, you don't have too much preeclampsia, and usually they would be easier to induce. Now, I don't know that for certain, but that's how I interpret it. Section rate of 76% in Group 5 is neither here nor there. I suspect if that kind of level of section rate, they probably have a low incidence of ruptures. I mean, that would be considered higher than a lot of other places, but in my view, at least, that's appropriate. I don't think it should be, certainly not below 60%, I think. Or if it is, you'll get more ruptures. That's really all I've got to say. The section rate in Group 3, ours was 0.7%. Again, that's slightly high. It may be because a few women here who have got previous scars have been wrongly being put in this group or wrongly being put in that group. I would guess that a few have been classified wrongly there, but it's only a guess in terms of, because that size of that is usually half the total size, and I think there's a few percent missing there. So apart from that, with the breaches, that's what I would look at. It's a very average incidence of multiple pregnancies. So I'm not quite sure whether it's a tertiary referral unit, but it may be because there are a lot of, there's a big Group 10 there. What I can say, though, is that section rate in Group 10, single quality, is not that high. So there may be a greater majority in this group going into spontaneous labor as opposed to iatrogenic. So that's my summary of that, if you like. I don't think I have anything to add, but let's see, what can you tell me about the hospital?
Are you able to see the next slide?
Yeah.
So it's quite a large tertiary hospital, which about 20,000 deliveries a year. So it is quite a busy center, and I think they have a lot of referrals. So I think the preterm could be explained by that. So this is the background of the hospital. It's a central government funded center with a large caseload.
Yeah, the groups I would analyze in more detail are Group 2 and Group 4. I will always be interested in group 1 and 3, but 1, 2 and 4 are interesting, but 1 and 3 are still high, but not that high, as we'll see compared to some of the other units. And group 10, I think, would be worth just seeing how many spontaneous, how many induced, whatever. And do you know what the perinatal mortality rate is there?
I can actually, if with your permission, I will sort of disclose which hospital that is, and maybe
well,
we
no,
can
don't
have.
worry, don't worry. Let's move on, and maybe we can come back. Unless whoever's from that hospital would like to say anything about my comments.
Yeah, I can just tell everybody which hospital it is, and then they can pitch in if that's all right. So this is the data from JIPMA. Dr. Dilip, are you there?
Yes, sir.
Hi, Dr. Dilip.
Yeah. So we get a lot of referral for hypertension in early gestation, and most of them we try induce, and sometimes we get eclampsias also, and a lot of IVF pregnancies with preterm labor. So being a referral center, we get that. So that group 10, the section rate is higher there. And perinatal mortality will be around 30 to 40. It varies per thousand.
Okay. Can I just ask you, sir, in the group 10 IVF pregnancies, are they ones going into spontaneous labor and you section them in labor, or are they sectioned before labor?
If they go in spontaneous labor, we allow them to deliver.
Right. Okay.
But many times these patients which are older age group, and then they have multiple other medical problems, and then those are the one who end up mostly in section, like with hypertension or other problems.
Yeah, the distinction I'm trying to point out is whether they're pre-labor or in labor, and it may be worth breaking that down. I quite agree with you. I mean, I think
a lot of them are pre-labor.
Yeah. But I would have expected a little bit higher section rate then. 35% is not that high, actually, if you were doing a lot of pre-labor. So I'd be interested to know how many you do in labor, actually. But anyway, yeah.
A lot of hypertension alone is a problem, means we induce them, even with preterm. So we do induce them.
Right, okay. And they end up in sections then, yeah, okay.
And most of them deliver.
Yeah, shall we move on to the next one, Santosh?
Thank you, Dr.
Just
Dilip.
keep going, yeah.
Yeah.
Thank you.
So hospital 2, that's the data from the second hospital. Again, I apologize that I don't know the time frames because it wasn't.
No, don't worry. No. It gives you the time frame will give me some information about the size of the hospital. Now, this is kind of, this is when it gets interesting. Okay, so 590 deliveries. Because I don't know the time frame. I don't know how big a hospital is, and you could say that 590 is bordering on, having enough deliveries to do the 10 groups. But anyway, assuming these all add up, you will see that, again, there's a significant nulliparous population, 40%, so it's about 46% overall. Again, the ratio is very 1-to-1 there, but it's 2-to-1 with multips, which fits. You've got an overall section rate of 71%. And you've got a pre-labor section, women with previous sections of 17%. I find that hard to believe within this population. I really do find that hard to believe, that there are not more women with previous cesarean sections. Very high preterm delivery rate. And you can see there's far more breaches here, 4.8%, which would fit with that increased preterm delivery rate. You can see group 9, 0.5, 100%. So it looks like a good marker, if you like, for quality data there in terms of the breaches. But I'm just surprised that there are not more women with a previous section here. I find that difficult to believe. Now, once we get to the section rates, I mean, 50% in group 1 and 43% in group 3. Do people remember what the previous one was and ours? Ours was 8% and 0.7%. I mean, in the order of trying to work out why that is occurring, the 3 factors are data quality, epidemiological variables, and practice. You've got to think of data quality first. And I would be very surprised. I'd bet a lot of money there's a lot of previous sections in these groups here for whatever reason. I don't know. Do you understand my logic, even though you may disagree with me? I think that there's something wrong. And I think the first thing to do is look at all the women in group 1 and group 3. Now, the other thing that may be contributing is this is a very small data set, but still it's very, very high.
Right. So if you permit me, I will just request the hospital.
Yeah, forget group 6, 7, 8, 9, and even 10. Forget those. The answer is in these first 4 or 5 groups, and you need to separate those out and just confirm that data.
Yes. So if I could call, the second hospital is AIMS Bhubaneswar. Is Dr. Saubhagya Chena, sir, are you available?
Good afternoon.
Good afternoon.
This data is for last 6 months data, and we get a lot of cases referred from outside for the good neonatal facility, which have complications. That is an important cause of lot of preterm deliveries, IVF pregnancy, and more cases of cesarean on request, and that to pre-labor request. Almost we are analyzing, at times it is going to almost 10% of the cesarean section rate.
I accept what you say, and the preterm delivery, is non-negotiable. I mean, I can see that, and I'm less interested in that. But in group 1 and group 3, these were spontaneous laborers at term.
Yeah. We are not able to find any cause, sir. Probably this electronic fetal monitoring.
Well, in my view, at least, I would start by looking at group 1 and 3 in more detail. I mean, and use that flow diagram that I showed you. Do you know what we need to know in groups 1 and 3 how many women went into labor and then requested a cesarean. We need to know whether it was fetal reason or some form of dystocia. We need to know if it was dystocia, was oxytocin used, was it not used? There are a number of questions, and I think that my opinion is, I'm not saying it's wrong or right, I'm just saying group 1 and group 3 are the ones that clearly stand out as need to be looked at and need more of an explanation. And please, doctor, don't assume I'm saying this is right or wrong. There may be all kinds of organizational issues, all kind of other things. But if I was in your position, I would have that information.
Okay, we'll get the information, sir. But the issue is, after induction, also after taking consent, lot of women request for cesarean section, and one of the important cause for them is tocophobia, fearing of the pain of labor.
Yeah, but we need that information within the groups.
Yeah.
Can I just take a general point here? India, for all kinds of reasons, and some countries that have got, data similar to yours, you've got a great opportunity to help the rest of the world to set the standards in order. We're not talking about right or wrong or whatever. We're talking about routine data collection, using classification systems that other people can learn from and copy. We're not talking about what's right or wrong. We all live in different countries, there are different cultures, there are different things. But I don't think, what I'm saying is, I don't think you can present figures like that without knowing all of the other reasons and how hard you work and what you do and what the reasons are. That's what I'm saying. Does that make sense?
Yeah. Yes.
Okay, next one.
Thanks. All right. Hospital 3.
Yeah, and you see, this is interesting. I don't know what year it was. 17% section rate, 2,500 deliveries, so a good data set. 27 and 25, 52% section rate, 52% size of group 1 and 2. So that means the total nulliparous population in this unit is of the order of 56%, 57%. That's quite low. That is really low. And I'm trained to look at data and see. It's quite extraordinary to see in a country like India. I mean, this could be a remarkable hospital and whatever, but for you to have that many nullips and to have such a low section rate in group 1 is quite remarkable. Anyway, it's a 1-to-1 ratio, so they induce a lot, but they don't do many pre-labor sections here. It's fascinating. You can't have a 19% section rate in group 2 and have that lower section rate. The only reason, I mean, it's quite remarkable. I'd love to know the perinatal outcome and maternal satisfaction. These results are quite remarkable in a country which has a background rate as high as India. So, I mean, it may be a very low risk population, but even if it was a low risk population, spontaneous nullips that go into labor, a 7% section rate is excellent. So I'd then want to know what's the outcome in labor, whether any stillbirths, any intrapartum births, were mothers happy, were they long labors, short labors, or whatever. But it really does stand out, and it's reinforced by group 3. 1.9% section rate in group 3 is very, very. I hate to use words like good and whatever, but it's low and very acceptable, as is group 4. But I mean, it's almost like they don't do any pre-labor sections in group 2 and 4. So they may ship all those pre-labor sections out. They certainly don't do any for maternal request there, as far as I can see. And the only other thing you've got to think of is, because there is so many nullips in this population, which is quite remarkable, I would ask, are they really nullips? Or could they actually be multips but misclassified? Now, I'm not saying it is, but I'm saying these rates are so low that you have to think of that. There was one hospital or a few hospitals in Scandinavia that had such remarkable low rates and section rates in group 1 and 2. It wasn't until they looked at the 10 groups that they realized inadvertently the computers had been misclassifying them as nullips when they were really multips. And the reason was their previous pregnancy hadn't been recorded on the computer. So all kinds of odd things can happen. But if they are nullips, it's quite remarkable, the outcome. And even if it was a low risk unit, those are quite remarkable figures in group 1 and 3, the section rate. If you look at the other groups, you can see there's not very many breaches. There's a very low incidence of preterm delivery. And most of those preterm deliveries are not iatrogenic. So this unit probably doesn't have a neonatal unit. They are, I would suggest, spontaneous labors that you couldn't move them. And the reason I know that is because the section rate is so low. Does that make sense? Yes. So I don't think I have anything else to say, really. And in this unit, I would just make sure, and I'd be very interested in the processes used for managing labor in this unit. I'd be interested in the intrapartum. The maternal outcome is excellent. I'd want to know about the fetal outcome and the maternal satisfaction outcome. But groups 5, 6, 7, 8 are irrelevant. There's still a significant amount of twins there, but anyway. Okay, I don't know whether anybody's got anything to comment on my comments.
If you allow me, I'll bring in one of the doctors from the hospital, if that's all right with you.
Yeah.
Yeah, so Anne or Vinod, are you there from chat?
Yes, we're here. So, like Professor rightly interpreted, we are a low-risk unit, and we do not have a neonatology unit. So we normally transfer our patients for preterm care to the main hospital. But perinatal mortality rate is about 9.2 per thousand. That is our calculation.
But can I just ask you, and I don't take, any, I'm only asking, are you pretty sure that there in group 1 or 2, you've got that many first-time mothers?
Yes,
more than 50%. Okay. Well, what's your secret in group 1 for managing labor? How do you manage labor in group 1?
So I think one is we are a community health department, but the obstetrics is mainly run by a few people who make decisions. One is induction of labor is done after we actually really decide a patient needs the induction of labor. And I think our induction process is also a little different from others. It's a little bit drawn out process. It's a little slow. So I think I don't know. That's the way I think. That's why it is different. I'm not sure.
I'm not. Yeah, but what about group 1 though? I mean, what's your oxytocin rate, for example? What's your length of labor? Tell me more about it.
Okay, so we follow protocols, like we follow the partogram. For those who are in active labor, we do assessment once in every 4 hours. Oxytocin means we decide on cesarean sections by the partogram, and if means not strictly by the partogram, but we use it as a guideline. Oxytocin duration, yeah.
What's your oxytocin rate in group 1?
I am not very sure. I'll have to look at that data again.
Well, what you need to do as a unit is you need to study and record all of those things for group 1 and 3, write it up as a paper and publish it in the Indian Journal. Okay. Because even if you're a low risk unit, in my view, a 7.3% section rate in spontaneous nullips in group 1 is not easy. You can't always predict who are going to be the ones that behave, well, and providing the outcome is good and mothers love it and, fine. I mean, I would love to know more about what you do then.
We don't have maternal satisfaction rates. That's not something we have followed up, but we do not do cesarean sections at request most of the time.
Well, that's obvious.
And
yes,
Prof is talking about the spontaneous labors. He's impressed with the spontaneous labor. So he wants to know if there are asphyxial admissions to the nursery.
Yeah.
that we can definitely look at the data, because we have neonatal data as well. We can look at neonatal outcomes over this period of time, definitely.
Okay. Shall we move to the next one? Shall we move to the next one?
If I can just add one more point, Santosh.
Yeah. Please.
Go ahead, Vinod.
Yeah. So just to add on, so in addition to what Anna said, the other rigorous procedure that we've been following, and that's probably for the last at least 30 years, is a monthly cesarean and perinatal audit. So all our perinatal deaths, all our cesarean sections every month are audited, and we look at processes, delays, unnecessary seizures, delays in seizures. And I think this has also contributed to everyone being a little bit more careful and watchful of how we go about it.
Well, can I commend you, because if I look at 10 groups and I see group 1 and group 3 there with a significant numbers, I mean, I respect what you're doing. It must be based on audit, a general interest, good leadership, working together. This doesn't come about just by luck. So well done, in my view.
Right. We'll pop to the next set. So number 4.
So adding the numbers up, it's interesting. I mean, this is the second hospital now. You've got significant number of nullips in India. I yeah, we can talk about that again, but I mean, you've got, 50% nullets here again, interestingly, less multips. You can see the ratio has been changing, again, with modern current interpretations of the advantages of induction. I'm not sure I agree in every situation. It has to depend on your own results, but you can see there's a ratio of less than 1 for groups 1 to 2, and that ratio is about 2 to 1 or just under 2 to 1 for group 3 and 4. So that fits. That's a very constant phenomena, as I've explained to you. The overall section rate is here is 35%. You've got a group size of group 5 as 9.6%. I would have expected it to be a little bit higher there. The only thing that may change this is if women only have 1 baby after they've had a previous cesarean section, which I think would be unlikely from what I know of India. But I mean, I would have expected that to be higher. The breech ratio is, as I've previously described, you've got a lot of twins here. Whenever you see a lot of twins, you've got to make sure that in getting the data, they haven't counted babies rather than mothers. But if that is the case, and it is a high tertiary referral unit, because the size of group 10 is big, you've got a remarkable number of twins. There must be an IVF production unit very close by or within the hospital, or they take referrals from elsewhere. So, and again, preterm deliveries, it's got a much higher section rate. So a lot of these will be before labor, in my view. Not that it's easy to induce preterms. So I'm not really interested in any of those. Group 3 is much higher than it should be if they are really group 3 and they haven't contained some of those women from group 5. But here I think there's an obvious example of a data quality issue. I will need a lot of persuasion to say that the section rate in spontaneous multips is the same or a little bit higher than induced multips or multips pre-labor section rate. Do you see what I mean? There's a data quality issue here. I'm sorry. Does everybody understand what I mean? I mean, that just doesn't make sense. This is very high though, and obviously this one isn't as high as the last hospital, but it's certainly very high. For interest, say in our hospital it's 8%, Scandinavian hospitals is about 8%, UK, I think the last time they published data is about 13%, higher in some units in the UK than others, but certainly nationally about 13%. So this is high, and the things that you need to do here in this unit, I wouldn't worry about group 2. I would look at group 1 and group 3 and group 4 to try and find out some clues. And I think there'll be previous scars. Well, it's not even obvious where the previous scars went. They certainly didn't go into this group because this is quite low for that group. I would imagine there's a lot of previous scars, or a few at least, in group 3. Anyway, high risk referral unit as far as I'm concerned.
Yes.
And
Yes.
they still should look at group 1 and group 3 and 4. I don't know whether they have any comments.
So this is actually us. This is CMC with so we're a tertiary referral center, an IVF unit attached to the hospital, and the neonatal intensive unit takes referrals from outside, and it's one of the large referral centers for a lot of preterms, sort of severe preeclampsias.
Yeah.
But
Yeah. So I wouldn't worry. I wouldn't worry about group 10. Good data quality, you can see from the size and 100%. The breaches are the right ratio, a lot of maternity. But even with a high risk unit, group 1 and group 3, they're spontaneous labors. We very rarely section them in labor for preeclampsia or something like that. I mean, there may be a few. So I would use the flow diagram and look at group 1 first and find out whether it's fetal or dystocia. And if it's dystocia, which one is it? And particularly, do you use oxytocin? Do you not use oxytocin? I'm not getting into a debate about how we use and whatever. I just want to know, is this due to dystocia in group 1? And of those, did you use oxytocin? That's just what I'm asking.
Sure.
Any response? Okay, was that the response? Was it, Santosh?
Dr.
Yeah.
Gigi, did you want to? Dr. Gigi,
Yeah,
did you?
basically we're a very busy unit. So, and we have every month there's a audit, and we're very intolerant to asphyxia because we also, our patients are paying patients. So asphyxial admissions to the nursery is not taken well. So we give them, a benefit of doubt. So I don't think we are so proactive. We're also, meaning, we don't like long labors. We do intervene much earlier than we would, because our patients come here because it's a not for profit, but patients pay their own fees, and so they're very critical. Women have only 1 or 2 deliveries.
Okay, I mean, I like, yeah, that reminds me, I wanted to say to Gigi that, well, 2 things. You've got an ally in me, and that I don't like long labors either. But the second thing was I really enjoyed your talk, and really enjoyed. I listened to it on the mobile today, and I really enjoyed your talk today. And I hear what you say about paying patients, but at the end of the day, we're clinicians first and foremost. And what I'm saying is, with a 21% section rate in Group 1 and a 6% in Group 3. I would expect you to know why you've been doing the sections, whether it's maternal request, whether it's fetal, So that's the first bar, I would say. You can't, in my view, have a section rate of 21% and 6% and not know why. That I would be critical. I wouldn't be critical that you need to do it. That's what I'm saying to you. That stands out to me in a unit that is obviously very busy otherwise. And if you can use that flow diagram, and I'll try and help you, you'll be amazed how interesting it will be specifically for your results in Group 1 and 3.
Absolutely. We'll work on that. Thank you.
Thanks. Just quickly move through the others. So Hospital 5.
Hospital 5, again, there's this pattern of a lot of nulliparous women. We don't have as many nulliparous women. It's a small, I don't know the time period, but there's only 560 deliveries. And as we go through more and more the hospitals, you be able to analyze them, not me. I'm quite struck by that there so far been no women that have been unclassified. I presume that you found unclassified women and corrected them. But anyway, so you'll see the ratio again. Well, the ratio is more similar here, very interestingly, but it's still higher in multips than it is in nullips. But there's more women here that go into spontaneous labor rather than be induced or pre-labor section. But again, the section rates, 28% and 18%, that's too high without knowing why. That's really high. I can't say it any other way. And again, there's a data quality issue. I mean, how can the section rate be higher in spontaneous multips as it compared to Group 4, which includes induced and pre-labor section? I don't understand that. So data issue, then epidemiological differences, and then practice. So we need to correct the data or check the data. I would be surprised if there wasn't more pre-labor sections. 9% out of 30, usually I say is about half of that. I think there's some previous scars missing, and by the looks of it, it may be here. It probably isn't here, but it's either there or maybe in those areas there. I don't understand why there's less breaches in nullips than multips when you've got so many multips and such a high preterm delivery rate. I think that's a data issue thing again. Does everybody understand what I'm saying? Unless you're very successful in converting all your breaches by ECV, and if you know the secret, please let us know and everybody else know in nullips. I don't understand why there are more multip breaches there. That's odd. Very few multiple pregnancies, which is strange for a high preterm delivery rate and otherwise maybe a high risk delivery unit. But it's interesting there that this is a good example. 11% in Group 10, but the section rate is a lot lower. That means I can even say they're not iatrogenic sections here. They're the cause of the preterm delivery rate is preterm spontaneous labor. Everybody understands the logic in that, do they? So again, groups 1, group 3 needs to be analysed. And I can't understand, well, you obviously do very little, well, you do a lot of inductions, how that section rate there can be lower than spontaneous nullops. It's a bit like this, lower than that. I mean, it doesn't make sense to me. So there may be some issue about data quality in terms of definitions, in terms of, do you all understand that? It can't be lower than group 2. And this one can't be like, that's the advantage of having group 2 as both of them together before you subdivide them. Very rarely do people add things together, but they're very keen to divide them up together. And that's why on the initial group table, 10 group table as the starting point, I don't think they should be divided up. It gets too confusing, at least for me. Okay, next one, unless there's any comment.
I think we'll move
Mike,
on.
could I just ask a question?
Yeah.
What would be the effect if you've got very limited intrapartum monitoring and you don't have CTG monitoring in labour, and you do a caesarean section for anyone you've got minimal concern, meconium liquor,
Yeah.
would you see that kind of effect
On that section rate?
Yes, on the spontaneous labour section rate.
Yeah, Andrew, this is what's opening up to everyone. We don't know, and in different cultures there'll be very good reasons for why there'd be a difference. Absolutely, but that's why that flow diagram that I was talking about, dividing fetal with no oxytocin as opposed to fetal after oxytocin, is so important. And I think that's going to be a bigger it's going to be a bigger help to a lot of countries in Africa and India where they have high section rates in group 1 and 3, which are totally unexplainable, but they will be once we divide them all up. The other thing is there's some units that don't use oxytocin at all. Now, I'm not getting into that debate, but then they will show that it's dystocia and not fetal. And people can decide themselves what they want to do. There's a unit in Africa, that a country in Africa that I'm dealing with, I'm helping with in a project. They've got a 25% section rate in group 1, and their incidence of oxytocin is 2% in spontaneous nullops. But they haven't got the reasons why they did a section. And the other thing to comment, and it may be true, that some of these figures have to be taken into account of, do they include the whole denominator as well? I was going to mention that towards the end. So in units in Africa and possibly India, a lot of the normal deliveries take place outside the unit, and it's only the ones with prolonged labours that go in. That may contribute as well, because then you don't have the denominator. But there are other tricks to show up that, and also to a certain extent, look, we've just got a system for starting to analyze. We'll begin to do that, and then we can, roughly speaking, include all the data from these periphery units. Now, it may be difficult in some of the rural units not to include the home delivery, all the home deliveries, but we have to make a beginning. Netherlands had a problem as well because they had so many home deliveries that they didn't always include them as a denominator, but they get their 10 groups from the National Birth Registry. But it's important to think of all the other reasons. For example, I'll give you another example. Sometimes if you've got a very high twin rate as an incidence of the size of the group, one of the reasons I think is that it's a marker for how many people don't come in. Because if you've got a high incidence of twins and all twins deliver in the hospital, if that incidence is higher, relatively speaking, to the other groups, it will give you an idea of maybe how many others don't come in, or at least some come in and don't get recorded. I hope I've explained that right, because you're only getting the new numerator coming in, and that will increase the incidence of twins where there's no IVF, no nothing, especially in some countries where they've got a low incidence of twins. How do you explain that the incidence of twins is 6%? It would be, I say, because you haven't got the population denominator to reduce that rate.
I can just see that Alice Bidmore Gray's been trying to get in for some time, I think.
Sorry, yeah.
Alice? You're on mute, yeah. You're still on mute, Alice.
Sorry. I just wanted to perhaps offer a comment from our experience with the Cradle 4 trial and the Phoenix trial. So they're both timing of delivery trials and late preterm preeclampsia. So we have a lot of women that are induced preterm from 34 weeks. And one of the key findings from the Phoenix trial, which happened in the UK, was that women who were induced from 34 weeks were more likely to have a vaginal delivery than a caesarean section. And although we haven't yet completed the Cradle 4 trial, anecdotally what I'm seeing from the sites in Zambia and India is a much higher C-section rate than we'd expect. But I think it kind of speaks to what we've already discussed with regards clinical practice and context, because what I've noticed, particularly in Zambia, but I suspect this may apply to some of these hospitals that we've just been discussing as well, is so instrumental delivery rates. And I don't know, I'd be really interested to know what the instrumental delivery rates are in these 5 hospitals, because certainly in Zambia, it's not something that is done. So whereas in the UK, we might be able to reduce our C-section rate by doing higher levels of instrumentals for a variety of different reasons, both training-wise and resources-wise, that option isn't available at many health facilities in a non-UK setting. And then, as we've already mentioned, I've noticed that people seem to have a much lower threshold for resorting to emergency C-section in, for example, spontaneously labouring primates, but that's because of factors relating to lack of monitoring and staffing. And so I think just that context, as we've said, is really interesting, and particularly the instrumental delivery rate, and whether there's any kind of pro forma alongside this classification system.
We have we have 20% instrumental rate in the main hospital.
Okay.
Is that overall, Gigi?
Yes.
That's
overall.
That's a very high rate for overall.
Yes.
The overall rate usually is about 13-14%, and maybe in nullips it's 25%. Yeah.
Basically, we are trying to get them delivered to get a empty couch for the next patient.
Yeah, no, and whatever reason. But in relation to the other point, I mean, this classification, remember what I said, is the starting point. You need to know how many sections we're at fully. You need to know how many, when people talk, I mean, you've got to know all of those things, because it's like a ball. If you push it in one way, it comes out the other way. I didn't quite understand what you said about inducing at 34 weeks. I mean, if you induce, some are going to deliver vaginally, obviously, as opposed to doing a cesarean section. So there will be more that deliver vaginally. But if they're nullips, it's not easy to, in my experience anyway, a nullip less than 34 weeks. And I don't know what other people think. So I'm not sure whether that is either part of the explanation of the problem or otherwise. But I agree with you about operative delivery rates. And I think, we could start talking about the ARRIVE trial. Somebody put a question there about, has anybody used the 10 groups to judge, randomized controlled trials? I wrote to the New England Journal, and I wanted to get the 10 groups for the data behind the ARRIVE trial, because that would have been fascinating, because in their induced arm, they had an 18% section rate and a 6% vaginal operative delivery rate. They're quite extraordinary figures. Anyway, so we move on maybe. There's some hospitals that, and I've got to go back to the delivery ward in about 10 minutes, but we can speak again whenever.
Sure, we'll quickly flick through the rest. Many of them are fairly similar. So number 6, again, this might stand out as one last unusual one.
Well, Santosh, maybe you can interpret this one. Do you want to? Or anybody, Gigi, do you want to interpret this one? I mean, on what I've said before. Or shall I do it? I'll do it. So basically, the most extraordinary thing about this is the ratio between groups 1 and 2. Less nullips, only 35%, as opposed to over 40%. And the ratio between group 1 and 2 is greater than group 3 and 4. That's wrong. That's odd. And I would immediately think about data quality. And forgive me, I mean, an 88% section rate in group 1 as compared to group 2, 42%. And likewise, group 3 and group 4. So I think there's huge data quality issues in this group, in this table. And that's why, before going any further, I can't even go further and interpret the clinical implication of this. I think it's data quality there.
Sure.
I mean, it may be a very unique hospital that sections everybody unless literally they're falling out, the baby's falling out when they come in. I don't know. But I mean, for example, how come we have a section rate of 58% in breaches, multi-breaches, and an 88% section rate in spontaneous nullips and labor? I mean, it's... And 58% in multiple pregnancies.
I think it's the data quality. Yeah, we can move on. Yeah.
Okay.
Yeah. They were done in a hurry.
Anything? So
no, less nullips than the other hospitals. Oh no, sorry, 45%. No, a significant number of nullips in all of these hospitals. And you know, remember, the larger the proportion of nulliparous population, not only the higher the section rate will be, but also organizationally wise or otherwise. Taking the US data in general, as far as I remember, the general size of group 1 and 2 in the US is about 31-32%. In a lot of these figures, it's been about 40-45%. So again, that's worth pointing out. The 1-2 ratio is higher than 3-4. Sorry, it's less than 3-4, which is commensurate. The size of group 5 is nearly half of the total cesarean section rate. The ratio breaches 2.3 to 1.4 is what I'd expect. There's a few IVF pregnancies or referrals. Group 9 is a bit bigger than I would expect, and group 10 is very big. And kind of an average section rate. Group 9 should be 100%, but group 1 is very high. Group 2 is probably appropriate, maybe a little bit high. Group 3 isn't too bad. Group 1 is the thing that stands out here really to me, and that's the one that they could maybe look at in more detail. But otherwise, this sounds like a busy unit, I don't, well, busy units, but certainly got a high referral unit here in terms of twins and preterm births. But obviously these figures, you know, preterm birth, I'm always relating it to Europe, if you like. But as somebody said early in the meeting, that we need to get research data, or not research data, routine data for India to see what is the norm in terms of preterm delivery rate, whether spontaneous or iatrogenic. So nothing really new to add on those, unless I've missed something.
Sure. I've just got Dr. Dilip raising his hand. If we could just quickly talk to him.
Yeah. Just to make a comment that in our setup, first pregnancy, most of the people come to a tertiary care center. But once they have a normal delivery, second delivery, they may go to local places and smaller hospitals. So that primies numbers are looking very high in early paras.
Well, this is so important for us for you, but for us to help to use the 10 groups, ask the questions, and then answers come about, you know, and writing it up, because we need the 10 group as a methodology, but the results will vary in different parts of the world. And exactly what I was saying earlier is that the denominator, it means that the denominator isn't there. And that's a reason why there's more nullets. But likewise, if you're looking at the section rate within a hospital, that's got to be then taken into context. I think you're on mute.
Do you have time for one more, or do you need to leave? I think you muted, Dr. Robson.
Sorry, one more would be great. Yeah.
Okay. Sure. That may be the last one.
Yeah, very similar.
Sure.
High number of nullets, a high section rate in group 1, group 3, and again, as we've discussed, they may be affected by the true denominator in the population, and we've got to bear that in mind. So, if there is any way that we can, account for that, or collecting how many births in a region, it may be worth, because all the sections are done in the hospital, but all the births may take place outside. So I suppose what we've learned from today, there are some very high section rates of spontaneous labour, but there may be a data issue in terms of the denominator to account for those. As far as everything else is concerned, I mean, this seems good data, very high level of preterm deliveries, and a high iatrogenic rate, but interestingly, not many twins. I'm not sure why that is. So maybe it takes high tertiary referrals, but not twins, or I don't know. I can't explain that. The size of group 5 is a little bit smaller than I would have imagined it to be, but and the section rates in group 1 and 3 are high for whatever reason.
Sure. I think we'll stop with the data. Do you have any concluding remarks that you wanted to give the group before you carry on?
No, I'm very impressed by your, very inspired by your interest, and there's a lot to do, but you can set the standards as much as any other country. This is uncharted territory at the moment. It's very simple. Most people understand it. A lot of people in delivery units get interested in it, so it's there for the taking. But I would get people to look at that classification for indications. There's a few exceptions, but they're very rare, and that information that it provides you will help you. And remember, nothing is right or wrong. There's only 2 hospitals in the world, those who know their data and those who don't.
Thank you once again. Thank you very much for sparing your time.
No, and I'll try and link in tomorrow if I can.
Thank you very much. Appreciate it.
Good luck. Enjoy the rest of the meeting.
Thank you.
Thank you.
Thanks very much, Mike. Much appreciated.
No problem.
Fascinating.
Look forward. And this is only the beginning. This is only the beginning, right? You can set the standards here. You can, write the papers. Good. See you. Bye.
Thank you very much. Bye.
Thank you.
So, can I hand over to either Dr. Weeks or Dr. Gigi to is there any other? I'm just wondering if there's anything else.
There is, diagnosis of labor is probably also an important thing. Spontaneous labor, diagnosis of labor. I don't know.
I think a lot of this, because when even the definition that the slide with the definition, and when I talked to Dr. Robson before, he said, I think a lot of people are confused about what those slides meant. I think the diagnosis of labor and things, he said there's a lot of variation. I think oxytocin, he wanted to know what regimes we use, not whether we use it or not. So I think there are a lot of, I think from what I understood was we've got to look at our data really carefully again. But I think there are systems that play here that are different from many other, from the UK, obviously. So we've got to look at, like Dr. Dilip suggested, and like many of you probably are aware of, so there are different setups. But I think teaching us to interpret this data and just eyeball it like he did, it was amazing. It was almost like he's looking at a CTG and deciding whether somebody needs a cesarean. It was fascinating to watch him just look at it and say that's so I think from my point of view, I think getting more and more hospitals to sort of just do their own 10 group classifications and then re-look at it and see how they, not a question of reducing cesarean section rates. I think that's where we misunderstood things many years ago, where we thought that this is a way of reducing it. I think it's just a way of analyzing it.
I think it's also some homework. Centers can go back and see if there's some way that you can. What do you think, Professor Week?
Yeah, no, I think it gives a fascinating insight, and I think he's quite right that he's saying there isn't a right, there isn't a wrong, this is an insight for us. It's almost holding up a mirror to our practice, and you may like what you see, and that's fantastic. Or you may think, I really like this, but actually this bit I'm a bit uncomfortable with, or this I can understand why we've got a high section rate in this particular group, but actually it's because we don't have any good intrapartum monitoring and people are too anxious about fetal outcomes. And that's okay. There's a reason why you do it, but then you say, well, actually, how can we work on that group? Because actually working on that group may have a big effect elsewhere. So I personally thought it was fascinating and really really stimulating. I can see that Dilip Maurya has had his hand up. I don't know if that's an old hand or...
No, this was the previous one. I don't know how to put it down.
I can do it for you, don't worry.
Yeah,
I'll put it down for you.
Okay, so the peripheral hospital that had very low cesarean sections, the Chad hospital, they don't have fetal monitoring. They only do intermittent auscultation. Will you correct me, Anne and Vinod? When do you stop?
Ma'am, we don't do intermittent auscultation anymore because the numbers have gone up too much. Okay. So we do have, yes, we've started CTG monitoring.
Okay. So if your section rate is low despite fetal monitoring, that's important to know.
But I think it's interesting. The fetal monitoring question is fascinating. In fact, Kate Lightly is doing her PhD on that, because it could reduce your section rate if you get reassurance and you're comfortable with the reassurance. Or actually what usually happens in the UK is that it increases our cesarean section rate, because you see a small dip and you go, and you rush off to doing a cesarean. So it can be reassuring. So you've got somebody with meconium liquor and you think, let's put the CTG on and it's normal, then it may reduce cesarean section rates. But in the UK, almost universally, wherever it's been introduced, it's increased the rates, because people think as soon as there's the slightest abnormality, then I'm taking responsibility. The machine says there's an abnormality, and I'm taking responsibility. Yeah. The lawyers are going to come in and say, look at that dip.
Yeah.
Whereas actually, if it's intermittent auscultation, then I'm saying it's normal, and that's the end of it. So it doesn't always produce the reassurance that I think everybody was hoping for.
Dr. Anne actually works both in the peripheral and does a day in the main hospital. And do you think you have some insight into why the primary and multi-cesarean sections are higher in the main hospital as against what is different that you do? Would you have any insight?
Ma'am, one thing is, interpretation of the CTG is very important. So having a senior person around, which I think our main hospital is doing now, a senior person around to interpret and decide, is it actually abnormal? Because a few variable decelerations are not.
Yeah, and this evolved out of many years of auditing. you know, we found that we were having asphyxiated babies. I said, unhappy neonatologist, if you had decelerations for 2 hours, those babies, that's still a false positive, but we had to, you know, do those extra cesarean sections if the decelerations persisted for more than 2 hours. So, yeah, the bottom line is that we couldn't have, our asphyxial rates are really low. We have only less than 1 per 1,000. Every month, there are months where we don't have asphyxia and no intrapartum death. Yeah. So that could be one of the reasons.
Ma'am, the other thing that I thought is probably the indications for induction. They vary across units.
No, but that is category, that is 2. It is Robson's 2. So that is different. I'm talking about 1. Yeah. Induction, definitely we should work on, but the spontaneous primary and the spontaneous multi, interestingly, indirectly in research, we have found spontaneous multis to be quite low. So I think data collection of this, the data, we should go back and look at data. That is the other thing that we should look, because indirectly in our research papers, we are finding cesarean section rates that are quite low in randomized studies in low risk patients. So anyway, it's interesting conversation. Dr.
Gigi, can I respond to you?
Yeah.
Gigi, I think, you know, both you, Santosh, and Ken correct me if I'm wrong, but definitely one of the reasons why cesarean section rates are going to be much higher in CMC as compared to CHAD is because you are getting all the complicated cases.
Yeah, but it should fit into the category.
And,
yeah,
and from all over at very often at very late stages, which is why you would expect Caesar rates to be much higher in a tertiary center.
Yeah, the other thing is the nulliparous IVF patient, we may not do the whole works. You won't do the way. It may actually be category 2. You're giving them a short trial, and so they come under category 1. So the high risk patients, that could also explain why we're not giving a wholehearted, though they're spontaneous labor, you're not waiting as long as you would in another patient because of their high risk factor. I don't know.
It helps in the UK. We in our hospital data, we have all the home births as well. So the hospital takes responsibility not only for those who give birth in the hospital, but the area around. And so even if they've refused care or they whatever they do, they're under that same hospital. So actually your denominator is fixed, whether they stay at home or come in. Whereas I think it distorts things a little bit when you're collecting just the hospital data, because even those intrapartum transfers in because they're having problems at home, you know, those are difficult to work into this system, I think.
True. So I think we've had a very good day. Thank you to the participants for actively being involved with all the deliberations. We look forward to having you back tomorrow. Professor Vivek, would you want to add something?
No, well, just to say thank you so much to everybody who's, and especially behind the scenes, as people who've been working hard to make sure the IT worked, and Kersana has been working hard on that. So thanks very much, Kersana. But I think this is fascinating, and this is we haven't got answers, have we, here? What we're doing is somehow laying out some of the issues, some of the problems that are around. What methods do we have of dealing with them? What are the differences? And once we can see more easily what the situation is, then and we'll do that again tomorrow. So we'll talk all about nurse midwives tomorrow. We'll talk about misoprostol regimes, and what we'll do then when we come back in January is to say, okay, so now then let's think about where those juicy areas are. Where can we start to work together? Where are the opportunities? Where do we get money from? How do we integrate together? How do we how do we form a network which actually produces results rather than just sees problems, because we want to see solutions. And these are part of it. So thank you very much to everybody who's contributed today. We start tomorrow at 08:30, which I think is 1 o'clock again, India time.
Thank you. Thank you for active participation. We look forward to seeing you tomorrow. Thank you.
Thank you. And see you tomorrow.
Thank you so much, everybody.
Yeah. Bye-bye.
Thank you. Bye.
Yeah. Bye.
Thank you.
Thank you.
Thank you.
Thank you.
I think if any of the steering group want to stay on a couple of minutes, we can just make sure that everything's okay and ready for tomorrow. A bit of practical planning.
Sounds good.
Maybe we should have said that before everybody left. Before everybody
we
left.
seem to have read each other's minds anyway. I can see yourself and Kate.
That's okay.
Do you have the ability to aid people to leave, Keats, or is it, or do you have that?
I'm never quite sure when it's polite to do that or when it's rude to do that. Of course,
no,
anybody's very welcome to stay on and join. Maybe people want to join the steering group. There's lots of jobs to do. That gets everybody off.
I'm not actually sure if I can anyway, to be honest.
I was just wondering. I always have this issue with the Glow webinars. I never know where to end it. People are often chatting in the text. We could always end the call and restart it, couldn't we?
That's right. Oh, Shuchita's there. Shuchita's there. Great. Hi, Shuchita. Is everybody else there wanting to be there, or are you there as accidental? If anyone wishes to join us, that's fantastic.
Perhaps people may have had this on in the background for a little while.
I think that's sometimes what's happened. They're working at the same time and actually they've been called away. So I'm going to take Shuchita, are you around to stay a couple of minutes? So I hope people won't feel offended if I start removing people. Okay. Brigadier Menon, I'm afraid I'm about to remove you unless you. Now I feel bad. This is dangerous. This doesn't seem very good, but I think maybe he's been called elsewhere. So
sorry, yeah, I'm sorry. I got disconnected in between.
Okay, so I'm removing people from the meeting now. Duncan Hospital.
Should I message Gigi and Santosh to ask if they want to rejoin?
Well, I have just actually, but yeah. Okay, well, I'm not sure there's a huge amount to say, but well done everyone. I think that worked really nicely. Well done for sorting out the IT behind the scenes. It's always a headache, isn't it? Yeah, well done, Kate. It's all very good, all good work, I think. So yeah, no, I'm delighted. I think it was great. And I think tomorrow pretty much the same. I think we can have longer. We could have had much longer in the group. And I think from my point of view, I started our group actually by going around and everyone introduced themselves and said a little bit about themselves, which it took 10 minutes or so. So that took more time.
If it helps, I've made a chart. I've rejigged some of the times. I think our introduction talk only really did need to be 10-15 minutes long. And I think we can do 45 to 50 minutes in all the breakout rooms if that's helpful, and we'd still run to time.
Well, it depends a bit on. Kate, you're doing tomorrow morning's introductions.
How did you feel about that, Kate? Or would you prefer to
you
have the
want
full
30 minutes or?
Well, it kind of depends. So I'd not made a final decision on which questions to ask. So I thought that session was actually not meant for me talking, but more just further breakout groups to actually get people talking. So I hadn't made a final decision on which questions to include, because I wanted to see what the dynamics were today. But actually, according to today's discussion, my 3 questions would be